Hello, everyone. Welcome to our webinar. If you could just quickly let me know through the chat function if you can hear me okay. Just want to make sure before we get started that all of you can hear me just fine through your microphones. All right, we're going to get started. So welcome to our provincial webinar. If you're here today to learn about what prescribers should know about COVID-19, substance use, and safe supply, you are indeed in the right place. So really the purpose of this webinar today is to walk through the new provincial clinical guidelines released by the BCCSU here in April 2020. We're going to do a bit of a didactic portion to this webinar. You can expect probably 20 to 30 minutes of didactic from our speakers. And then we're going to leave lots of time for you to ask questions. I know really the purpose of this webinar is to see how you're doing in your area of the province, how we can support, and how you're providing care to your patients. So let's jump right in. So before we get started today, I just want to respectfully acknowledge the land on which we're working here today is the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And just to note that this is a provincial webinar, and so taking a moment to reflect on the lands in which you are attending this webinar today, and how you're appreciating the people who own these lands. So here's our agenda today. So I'm gonna just, I'm the moderator today. So this is Amanda Giesler speaking from the BCCSU. So I'll be introducing our speakers, but really quickly as an overview, we'll go through our learning objectives, the background and context. We'll be looking to overview the Safe Supply Guidelines, some more specific guidance around OAT, and then some case studies specifically around safer supply, and then lots of time for questions and discussion. And with that, I'll introduce the amazing speakers that we have lined up for you today. So you should be quite familiar with these three already, but just so you know, Dr. Christy Sutherland is the Physician Education Lead with the BCCSU and a family doctor providing care for the downtown east side at the Portland Hotel Society, where she is also the medical director. And it's worth noting that Dr. Sutherland is Canada's Family Physician of the Year, so we're really lucky to have her on today. We also have the amazing Dr. Rupi Brar. Dr. Brar is the family care, one of the family care physicians at the PHS on the downtown east side, and she's also an addiction consultant at St. Paul's Hospital and a clinical assistant professor with the Department of Family Practice at the University of British Columbia. And last but certainly not least, we have Guy Filicella, and Guy is a passionate advocate for vulnerable people who suffer with addiction. He spent nearly his entire life suffering from the same disease and now educates folks and communicates on harm reduction principles through his public speaking in efforts to eliminate the stigma that exists around it. He's also employed by several folks, including the BCCSU, Vancouver Coastal Health, and the Ministry of Mental Health and Addictions. And with that, I will pass it over to Dr. Brar to take us through the guidelines.
Thank you, Amanda, so much. And so thank you, everyone, for your time. Oh, sorry, Amanda, I don't have the screen in front of me. Let's see. I'm not quite sure what happened there. Sorry, everybody. Let me just see if I can get access to that screen again. Amanda, do you know why that may have happened?
Just flagging to our technical team to give Rupi access to share her slides.
Okay, that's why that's happened. Sorry, everyone, we're just figuring this out. Just be a minute or two.
Yeah, while we're figuring it out, I can say from my little COVID self-isolation time that I put on a blazer on top of my stretchy pants, thinking that you would see me from the waist up. I thought that you guys would be able to see me. It's Christy here. And then my other COVID related house isolation challenge has been that I always put my headphones through the wash over and over. And so it's really hard to see me sometimes or to hear me. So I apologize if I'm crackly. It's because I'm disorganized with my belongings. Like every pair of headphones I've had, I've put through the wash, I feel.
Rupi, did you get access to the slides?
I'm not able to see them on my screen. Is everyone, Christy, can you, for example, see my desktop? Is that what you're seeing?
No, I can't. I just see the welcome page from Raman.
Yeah, I don't see Amanda. Unfortunately, the slides on my desktop right now.
Maybe Amanda, you could do the slides?
Yeah, I'm happy
and
to
then
do
Ruby
that.
and I can just chat.
Yeah,
okay.
If Lisa wants to give me access again, I'm happy to do that.
Perfect.
All right, sorry for the interruption. Over to you, Dr. Brar.
Thank you, Amanda. All right, so we'll flip down. Oh, this is a slide. All right, thank you everybody for your time today. We really hope that this is a helpful webinar, and we'll try and definitely answer as many questions as we can as we move forward supporting our patients who have substance use disorders in the context of COVID. So some of the learning objectives, we're going to describe some key strategies for risk mitigation during this dual public health emergency, discuss some appropriate pharmacological interventions, keeping in mind and appreciating the complexity of substance use disorders and the diversity of care that's happening across the province. To employ strategies to facilitate continued access to medications in the context of COVID-19. So in the context of this pandemic, how we can better support our patients there, and to develop a contingency plan for our patients. So moving on, as all of you know, March 11th, the World Health Organization declared COVID-19 a pandemic, and by March 17th, BC declared a public health emergency. Social distancing measures meant that there were maybe reduced hours of operation of pharmacy and clinical services, which we've all now seen. And it also means disruption of the drug supply for people who use drugs, which in fact, I've had discussions with many of my patients who describe this being a real thing. And one patient saying that her dealer only actually had 3 days worth of opioids left, and she was worried she'd have to find someone new and not know what drugs she was getting. And so the aim is to employ strategies to ensure safe access to substances to reduce the risk of harms and death that can be associated with destabilization and or withdrawal. One thing I forgot to say though is that Christy and I are actually sharing these slides. So Christy, please at any point jump in, and I usually speak way too fast, so I'm going to slow down now, and please jump in and add comments wherever you see fit. So
Will do, yeah. I won't hold back, Ruby.
No, which I'm glad about. So supply guidelines. All right, so we'll go next. And so these new guidelines to manage withdrawal, cravings, and other harms from opioids, stimulants, illicit benzos, tobacco, and alcohol were put together quite rapidly in the context of the COVID-19 pandemic. And the goal is to support our patients to self-isolate or maintain physical distancing and avoid substance-related harms. Now, this isn't substance use treatment, as we all know. For example, the stimulant section describes dexedrine and methylphenidate as protocols, and those have been studied extensively, and there isn't great evidence to show that it leads to sustained abstention from street or illicit stimulants, but we do know we can use them in the context of safe supply. So these protocols are to provide a supply of substances to help our patients, to help mitigate harm for our patients. All right, next. Thank you. So eligibility, this is a key question that's come up, rightfully so, frequently in the past couple of weeks. So who's eligible for this safe supply? So number one, people that are at risk of COVID-19 infection. So we all are at risk. All of our patients are at risk. But in fact, our patients who have ongoing active substance use disorders are more at risk. So if somebody has to leave their home every day because they can only buy enough for a day's worth of substances, they're at a higher risk of COVID-19 infection, but they may not have symptoms and they may not be positive. Someone who is confirmed positive definitely is eligible, and someone who has a suspected case, so they're symptomatic and they're wanting to self-isolate or they're pending diagnoses, all three of those groups are eligible. And then, of course, they need a history of ongoing active substance use. So somebody whose urines that from, your patients and they have some ongoing active substance use disorders, that's a criteria that's necessary. So if you've got a patient on methadone for the past 10 years who has had negative urines and is on carries and isn't using actively using other substances, they don't meet criteria number 2. And then criteria number 3 is if they're at risk of withdrawal, overdose, cravings, or other harms related to drug use. So again, somebody who isn't currently using other substances wouldn't be at that risk. But definitely this criteria means that anybody who has an active ongoing substance use disorder is eligible based on these criteria.
Yeah, I think that this is really important to think about, because I think about whenever we're sort of thinking about harm reduction and changing the framework of how a system operates with like a harm reduction lens, I always think about my own life and the luxury I have in my own life of like being safe and having a door that locks and having clean running water and having all the food I can eat, like too much food really, and having entertainment and connections with my family. And then I sort of use that lens to say probably people with drugs would also enjoy that safety and that luxury. And so how can we set up the world to make people safer? And I think that that really is the view with this document. And then as well to say that the substance use doesn't have to be daily use. And that's especially important with our stimulant users because they often do have a binge pattern and are not daily users. So if someone comes in and says, I smoke crack 2 times a week, and you're chatting with them about the plan, you can make the plan tailored to how they're using crack currently. But daily use is not one of their criteria, just ongoing active use.
Thank you, Christy. Okay, we can go next, Amanda.
Oh, but and to also note that youth and pregnant people are not excluded from this, but those are definitely special populations that deserve special consideration. And that for me, if I had a youth or a pregnant person, I would be phoning up a friend to discuss the complexities of each of those cases.
All right, thank you. And how did we develop these guidelines? So looking to the literature and our clinical experience in IOT, in the tablet injectable opioid agonist therapy program, in current existing managed alcohol programs, nicotine replacement, and unpublished research from Vancouver that showed that illicit hydromorph use decreased illicit fentanyl use. And now Christy and I are going to get a bit more into these, so we'll go to the next slide. So nicotine replacement, it's well established. We have really good evidence for this. We all feel very comfortable prescribing this, and we know it's safe. So really it's replacing a harmful substance with the same substance, but just a safer mechanism. So I think vaping is a good example of that for somebody who smokes cigarettes, and ultimately anybody who can have some NRT and smoke less, we know that's safer. For IOT, it was originally giving heroin in an illicit heroin context. In Europe, we have upwards of 8 randomized controlled trials about using IOT with heroin to support people, and it shows it reduces illicit drug use, there's good retention to care, reduction in sex work, and improved health and social functioning.
Yeah, and to add to this, I have to say when I first started prescribing iode, it was in 2016, and I was very nervous about it. I thought that every single other patient would throw their methadone at me in anger. I thought the building would burn down. I just had all of these sort of catastrophic ideas about what would happen when I started that first patient on iode at the Portland Hotel on the downtown east side. And what just happened was she just got better really quickly, and the other patients would come and talk with me and be like, oh, I'm so glad that you did that for her. That's so lovely. While I'm here, can I go up on my methadone? So I found that, people care about each other, and they're really happy to see their friends get better as well. And that people didn't reject OAT. It was the opposite really in our IOT program, that often people would start IOT with a view to transitioning to a higher dose of oral OAT. Like I remember one patient, I was so impressed. He knows more than most med students, I think, about opiate conversion, because he'd say, I'm moving next week, but I want to be on a really high dose of methadone, so I'd like you to start me on IOT now, and then I'll convert over next week. And I was like, oh my gosh, that's just so impressive. So I think, probably as a group in BC, we're all going through those same thoughts and worries and growing process as a clinician that that some of us have been through with our IOAT experience.
Thanks, Christy. And to add to that, in the RCTs from Europe on IOT, they've shown that, methadone treatment programs didn't have reduction in their attendance because IOT was now an option with heroin. So that's helpful too.
The other interesting thing about the IOT literature, I think, is that people are not on it forever. In Europe, the average is 3 years, and in our program, it's like 3 months to a year that people stay on the program. and that the doses that they're on are not the maximum doses. In Europe, in the cohort studies, about half. In our context, which we're offering hydromorphone in a fentanyl context, it's about 75% of the maximum. And often it's very similar to methadone, where you're trying to encourage people to go up on the dose to get stability. And that person is saying, oh, no, doc, I'm going to stay here at this lower dose so that I can taper off more easily, because they have a goal of being on nothing at all. They really see it as a ball and chain. And so I find people are very thoughtful about the dose that they need, and often need encouragement actually to go up to see elimination of that fentanyl in their urines.
Great. So the next slide is about the tablet program, which is actually really helpful in this context. And Christy, can you just take it for this slide, because this is really the work that you've been doing and you can best describe it.
Oh yeah, so for our tablet program, we developed this because patients who are on IOT would ask me, how many DILI-8s am I taking? And I would do the math and I'd say like, oh, you're on 45 DILI-8s. And they would say, no way, 45 DILI-8s would kill me, because they'd be on like 200 milligrams of hydromorphone and 1200 of KD a day, looking bright-eyed and bushy-tailed, you know, like bopping around, living their best life, feeling annoyed at us that we were doing this 15-minute post-dose observation period. And they would tell me like, I don't need this much of drugs. Like, this is too much. Actually, I just need 2 dilaudid 8s and I would be fine. And I just found that so intriguing that very consistently people were asking me for less drugs, but just in a tablet formulation. So Rupi, I have to give credit to you, did our ethics application, and we designed this program together. And it started in January 2019. And we picked people who were at the Molson overdose prevention site and were frequent overdosers, because that was the patient population that we really wanted to target. And this program's embedded inside the overdose prevention site. So we have 60 people on the tablet program, and then they were doing so well on it because it's as needed, PRN. You can come and go as you like, you can miss days, because I was really thinking about that death panel review that showed that people in and out of jail are at such increased risk of death. And I'm sure so many prescribers on the line who are OAT prescribers, like I can't count how many Friday evening phone calls I've had from a pharmacist or an outreach nurse saying, so-and-so just got out of jail, it's a long weekend and they don't have their methadone prescription. Like, that's happened to us all, I think. And so for TIOT, I made the prescriptions open-ended and PRN. So thinking about that patient population as, you know, someone's out of jail, it's Saturday night, it's 7 p.m., where are they gonna go? Well, if you're on this program, you can come here and just restart your medications there with the nurse. After a while, I thought, oh, it's probably not actually the tablets that make this magical, even though that's what the patients would report, that they really like the tablets. And so we started another 20 people on the injectable formulation with just the same framework of the patient-directed timing, the PRN, and the fixed dosing. So there's no titration, because people would get quite frustrated with the titration. And since we started this program 14 months ago, so 60 people on the tablets and then 80 people in total, we've had no overdoses at all. They have reconnected with family, engaged in primary care, they're getting their hypertension teed up, or doing Hep C treatments. Claire is the physician attached to our TIOT program, and I have to give him a shout out for what a wonderful job he has done with this patient population, just getting his FIT testing, his pneumovax vaccines done. It's just been amazing. The other nice thing about it is that people really want to titrate their OAT. So often, especially if they're on Kadian, you can take the tablets that they've had in the past week, you can look at their medication administration record and go up on their Kadian a bit more quickly. And we've had people who are either on no OAT or quite subtherapeutic doses of OAT when they start the TIOT program, start OAT and then get up to a nice robust dose, so they just feel more comfortable. We've had very few adverse events, I think 6 cases of cellulitis and 1 case of osteomyelitis. And in all of the cases, the people had ongoing stimulant IV drug use. So we've had so much learning, I think, from the TIOT program in just our clinical comfort in prescribing short acting on top of OAT, so that someone is on OAT and then still using fentanyl and chipping away, and then you add on a short acting for them that is a PRN, and it really helps them.
That's so helpful, Christine. That's exactly what the next slide is describing as well, that just like IOT and TIOT, you can add safe supply in addition to their baseline OAT. I started a patient on safe supply. In fact, this person was COVID positive and they didn't want any OAT. But then after day 2, they felt that, you know, methadone really was the thing that held them the longest. So they asked for OAT on top of the hydromorphone. And now we're just up titrating their OAT. So, you know, in this context, consider how much they're using on top of their current opioid agonist therapy. Consider how much money they may be spending on illicit drugs. So if someone's saying, well, you know, I'm using about $50 a day on top of my methadone 150, that tells us they're using approximately 2 to 2.5 points of illicit opiate on top of that. So they definitely could utilize some hydromorphone to avoid having to go find that money and then find the find the substance that isn't generally safe. So the other thing you can do is review urine drug screens, of course, to see that there is ongoing illicit substance use, and then titrate up the OAT as per our guidelines. So we keep reinforcing, the evidence that we do know that methadone and KD and Suboxone have evidence, and we can optimize that dosing, but still support our patients who are needing to use on top of that, because we all have people for the past, however long you've been practicing, who no matter what, their urine does still have a little bit because it continue to chip away, and that may be for many, many reasons. But in those contexts, we can really support our patients with some hydromorphone, for example, or dexedrine to help prevent harm there. So managed alcohol, so replacing illicit non-beverage alcohol with beverage alcohol observed or daily dispensed has decreased risky behavior reported. Participants report increase in personal security and control over their drinking. There's periods of abstinence. There's decreased crime, decreased theft, decreased interactions with, that should say police, sorry, not policy, improved relationships with family and connection with primary care. Christy, you gave a great example on our chat today about people who use MAP initially to their max, but then end up using less. Did you want to describe that?
I really have noticed over the years of doing MAP that, when you're a non-beverage alcohol drinker and you're homeless and you have seizures, my goodness, like life is pretty tough for you, because you're always drinking to avoid seizure, and you're always worried that your alcohol is going to be stolen from you. And you're living in the park and trying to drink as quickly as you can so that you don't seize and you don't get assaulted. And that is quite rough. And so when you start someone on a managed alcohol program, you sort of just give them some breathing space, where often at the beginning, they will always take the maximum amount because that's what they've been doing for 20 years living on the street. And they're so anxious about having a seizure and so used to uncertainty in their life. But then over the weeks and months, as you just continue to be quite kind and the alcohol is consistent, and then you're like, oh, do you want to take a little break on a detox? Let me look at your knee. Do you want to get an x-ray? Doing all these lovely primary care things at the same time, they can have a breath and they can sleep a little bit and be like, oh, okay, they can let go a little bit of that anxiety. And so we see in managed alcohol programs that people drink less over time. And sometimes people taper off managed alcohol to no drinking. And they can have increased periods of abstinence because of that security. So you can talk with people, we call it a liver holiday, and say, let's look how your liver enzymes are going. Let's look at your health. How are you feeling? Why don't you just go spend a week at detox and see how you feel, and then come back? And just knowing that they can come back to that managed alcohol gives people the security to have some abstinent time. And then as well, it's quite nice because we often will pair an naltrexone or a cambrisate, although I think it's still on shortage, inside our managed alcohol program. So we'll say, okay, what's your goal? Oh, you want to decrease how much you're drinking? Let's start a little bit of naltrexone while you're here, and we can map it out over time and see how your trends go. And then why don't I put a little alert in your chart? Let's check your liver enzymes in 3 months and see where you're going. And it's really lovely clinical care to provide to people, I think, and that people really appreciate it. And then they reconnect with their family, their housing is more secure, they start on their ARVs, and then they're drinking less, and it's so nice to celebrate those wins together.
Right. And there is some unpublished literature that I think once published will be supported, but there's a signal to indicate that using illicit hydromorphone decreases the amount of illicit fentanyl a person uses. So, I mean, we really want to be decreasing harm in the context of this safe supply and in the context of our prescribing. And, we do have some literature that's yet to be published, but that we can see, and from our own clinical experience that we know, again, from the tablet program as well, where we dispense hydromorphone tablets, we know that in fact, the risk is that the chances that we're reducing the risk, at the very least keeping it the same, but not increasing the risk in the context of safe supply.
Yeah, I think that's such a good point, Ruby, and that these are all individual decisions within this framework. So we can see of this tool as like a framework for how you talk with your patients about their needs and their safety. And it's always a balance for each individual that the clinician and the patient discuss together to make a shared decision. I put in the slide about pain because I think that this is really a big learning for me in prescribing IOD, in that a lot of people take drugs because they're in pain, but IOD is not treatment for pain. So I have had some referrals for IOD for patients who are not injection drug users, but who have chronic pain, to start them on IOD. I was like, well, no, that IOD is not treatment for pain. It's treatment for opiate use disorder. But many people with opiate use disorder report the reason they use is pain. So for me, it took a lot of years actually of unpacking these two things. And so now what I look at is I say, what is your risk of death? what are your urine tests show? You're telling me you use for pain, but you're injecting fentanyl. You've had overdoses. You've been on methadone, and you still have your fentanyl positives despite your methadone history. So that the reason that that person identifies as using drugs is sort of independent from how we as clinicians talk with them about their risk of death. And so pain is not a contraindication for this safe supply program, just the same as it's not an indication. We're not starting these hydromorphone tablets for people for pain. We're starting them for opiate use disorder because of their risk of death. And the risk of death is sort of twofold to consider right now, from overdose and from COVID. But it's a lot to unpack, and I think it really, as clinicians, like it takes a lot for us to have these really fulsome conversations with each patient, and it's so much easier to have it with a patient who you know well. But just to sort of plant that seed in your head that next time you're sitting with a patient and they're saying, oh, I don't have addiction, I have pain, and you're looking at their urine drug testing and their overdose history and their Narcan kit in their hand, that we can sort of take those things apart of like, what is your risk of death and what is your experience of pain in your life or why you're using drugs.
That's great. Thank you, Christy. We'll move to the next slide, Amanda. Thank you. So this, the medications currently in our guideline, we have opioids, so opioid agonist treatment. Of course, we want to offer this to all patients. You may come across patients who now want to start OAT because, again, there is a dwindling street drug supply. So, you know, if they're not on it, starting them on OAT, increasing their current doses, giving carries as needed. And then for those who don't want opioid agonist therapy, providing them with oral hydromorphone, so the DILI-8s, dilaudid 8 milligrams, or Meslon. From conversation with people with lived experience or living experience, they've described hydromorphone and Meslon as a two pill form opioids that would be helpful. Another great example from our tablet injectable opioid agonist therapy program is that we've been giving people 2 dilaudid 8s up to 5 times a day, and frequently we're told that that dose isn't high enough. So some of the recommendations are using, if someone uses 3 times a day, maybe 24 milligrams 3 times a day, so 3 tablets. That's one way to look at it. But again, Christy and I will get into a few case examples in a few slides. So for stimulants, we've recommended dexedrine or methylphenidate. We do have, trials where these medications are used with people with active substance stimulant use disorders. We do know that it doesn't help with sustained abstention or negative urines, but we definitely can say that we can provide this safely in the context of safe supply, keeping in mind things like, angina or active psychosis or a history of that. And then benzodiazepines, careful dosing.
I was going to jump in there about the stimulants. For me, this one was the biggest leap in terms of going from what the literature is to how we're prescribing in this guideline. And so I've done a lot of sort of thinking about that, about why I feel comfortable prescribing it now, where I was not doing any stimulant prescribing before. Like, well, our whole team at the PHS, we weren't doing any stimulant prescribing for stimulant use disorder. And I think for me, the difference really comes down to that the indication is different, that we're not prescribing it for stimulant use disorder treatment. We're prescribing it to try to help people protect themselves from COVID. The other things to consider with the stimulant research is that the doses were ADHD dosing, so that as that literature develops, hopefully the doses will go up to sort of meet the needs of maybe a crystal meth user, which might be quite different than someone who has ADHD. The trials are shorter, like all addiction trials, that often it's 12 weeks, and that the literature is still being developed in terms of the outcomes looked at, that often it's urine drug testing and retention to care as the 2 main outcomes. Whereas I think, especially when we look at opioids and as we get more literature, we want to know about quality of life. Like, are you reconnecting with your family? Are you working? Are you housed? Are you taking your ARVs? How is your mood? How is your sleep? And those things weren't addressed as much in that stimulant literature yet, but that is still, I think, research to come. And so those are the considerations in my head of why I was thinking how I'm changing how I prescribe stimulants for this context.
Christy, that makes so much sense. With regards to benzos, careful dosing is really important because we know that street benzo supply often isn't as accurate. So if people are buying Xanax, for example, they may not really be getting a pill with just Xanax. So the recommendation in the guideline currently is to give about 50% of what the patient is describing and then go up with follow-up. I mean, benzos make all of us really uncomfortable. It makes me very uncomfortable as well. I've always had a no benzo policy, except for treating people's benzo use disorders with a taper. And so, the BCCSU is going to put out an update to these guidelines where there will be a recommended approach of actually doing that. So offering the patient, you know, what they're using currently, but then transitioning them to a long-acting benzo like diazepam or clonazepam, and doing a very, very gradual, prolonged taper, and then eventually getting them off the benzos. Because, you know, as Christy mentioned, with opioids and stimulants, we've got data with opiates and with stimulants. With benzos, though, we have enough data to indicate harm that we, like, ongoing long-term benzo use is not recommended. And so we would recommend a bit of a taper, recommend a taper along the way. Christy, anything you want to add to the benzo section?
Yeah, I guess that it's sort of similar, but maybe on a different timeline of what we were doing before. That if you had a patient come to your clinic and say, "Oh, I'm buying, 3 milligrams of Xanax a day," before COVID, we might have asked our colleagues at Vancouver Detox to admit that person for a few days to really get a good idea of what their benzo need is and have it in diazepam or clonazepam. I usually ask the person which they prefer, and then taper them over 6 months to a year in community. So this is similar, but we don't have sort of that luxury of really knowing the dose because we don't really have the opportunity because of COVID to have that time in acute or in Vancouver Detox or whatever the context is for wherever you are in BC to figure out their dose. So it's a bit more of a shot in the dark. So that's why you want to start low and go a bit slower and have frequent check-ins with these patients to make sure you're not overdosing them. And then you can start with what they're taking now. So if you have a patient who says, "Oh, I'm buying Ativan and I'm worried about COVID and I've got COPD," it's okay, I think, to give them Ativan. Although, I mean, you really want to document well that you've talked with them about their risks in terms of their underlying respiratory conditions and things like that. Especially if they're co-prescribing opioids. Like, I mean, it can get quite uncomfortable as a prescriber, I think. So you want to have a really good discussion with them about the risks in their life and their understanding of the indications for these medications. And then over time, as hopefully they stabilize, then you say, okay, maybe 6 months from now, or, whenever we have a COVID vaccination, we'll say, okay, now we're going to switch you over to clonazepam and we'll do a 6-month taper. But I think it's very patient specific and prescriber specific for how your timeline goes. For myself, I'm never in a rush with my benzo tapers. I often take 6 months or a year, and I find that that's, okay for my patient population, but it definitely is very individualistic.
Yeah, and I can foresee a lot of people that are using illicit benzos that would really benefit from a prescribed taper and that ongoing engagement with their provider at that point versus not being able to get access to that, so having to continue to use illicit. But having that taper, and then again, knowing that with many other medications that with ongoing brief interventions, there's evidence. And so really supporting people with active benzo use disorders might be able to, at this point, get some support there. Moving on to alcohol and tobacco, we've talked about nicotine replacement being helpful, so that's something that we can definitely prescribe. If someone wants to stop drinking alcohol, definitely doing a pause score. If anyone hasn't yet seen the alcohol use disorder guidelines that were published by the BCCSU just in December of 2019, please do check them out on the website. They're extremely helpful, and they have the pause rating scale there. So if they have a pause of 3 or less, you can really do a safe detox in the community if they'd like to stop drinking. You can, again, as Christy had mentioned in the MAP slides, provide naltrexone or a camprosate to support them. And those guidelines really get into the specifics of these two medications. And then seizure medication for alcohol withdrawal. I mean, what this really means is, if I have a patient who has really good who I can provide really good follow-up for, who maybe lives with a loved one who can check in on them. And there may be indications where someone who has a pause of greater than 4, where you could potentially support them in the community in the context of this pandemic, when we know that admissions will be decreased and we can't just easily send them to detox. And of course, managed alcohol or tobacco programs are available in some places, but really being able to support our patients currently to not have withdrawal during this time and to decrease some of their suffering there. Guy, this is your slide. So I'll hand you over to Guy Felicella.
Hi, everybody. Thanks for having me. Can everybody hear me?
Yep.
All right. So, safe supply and before I get into the slide is something that I'm very passionate about, just because I've been brought back to life 6 times at the supervised consumption site in Vancouver. And when I put it into context is that 20 years of having a heroin habit, I never overdosed once. And then when the contaminated drug supply hit the market, within 9 months, I'd been brought back to life 6 times. And that took not only a physical toll on me, but also a mental toll. And so in these challenging, unprecedented times, with adding another layer on top of it, COVID makes it extremely challenging for people to actually survive. And I think about opiate use disorder. When I was actually diagnosed with it, I thought that was a relief in the beginning, because I thought finally I'd be able to get the help that I need to get off these contaminated street drugs. But unfortunately for me, it became a curse. And really what it meant is that you fell into a box of certain rules and rigid regulations and of what you had to do every day just to go to get your methadone, to be witnessed, the trust factor. And so for me, it never really worked for me. And I continued to use street drugs. And in these challenging times, what we have on top of this with the COVID pandemic is that withdrawal waits for nobody, not even COVID. So nothing will deter people from having to get rid of that sickness. And so in order for people to actually have the ability to practice physical distancing or even, possibly stay in their house, there needed to be something else implemented in order to support substance users. And so with this new safe supply guidelines, this is what it gives prescribers the opportunity to actually prescribe a safer pharmaceutical drug in order for people to not be so hell-bent on going out every single day and having to do what they need to do in order to get well. And so the challenge for everybody is that, we fit everything into these compartments of, clinical practice. But what I'm asking prescribers is to actually look at the harm reduction side of practice. And if you have patients that are even on OAT, but continuing to use contaminated street drugs, then naturally they would fall into these parameters to actually get a safer model. And so in this easy digestible document that BC Drug Wars survivors created, it really kind of explains it to being so simple and so easy. And it's really powerful because, the stories that I know a few people that have gotten on Safe Supply, and they've already called me and talked to me about their health improving. They're able to, not wake up, their anxiety levels have gone down, their mental health's improved. So there's so many benefits that I already see happening at the very early stages that makes it really beneficial for people to actually, not run the risk of getting COVID. And also you have to really think about, if you're actually not prescribing to somebody that's continuing to use street drugs, knowing all this, don't you think that it would be better to actually give them the pharmaceutical grade so that they could actually, not only protect themselves from getting COVID, but protect other people in the population from getting COVID as well? So it's really kind of one of those things where you have to use the harm reduction side of things more than the clinical practice side of things, and say to yourself, okay, hey, they got these new guidelines out, I can follow them, I can do them. And they're not radical guidelines. They're actually sensible. And in these challenging times for people, and people continue to struggle immensely, and this is a way to actually alleviate that struggle so that people have this safer supply, so that they have the ability to improve the quality of their health, but also the health of others. And so, yeah, I think that's pretty much, what I've got to say about it.
Hi, it's Rupi. Thank you so much for that. And I just, is this guideline or us writing prescriptions the answer to the overdose crisis? I personally don't think so. I think we need a safe supply on the streets. We need there to be access to safe heroin and safe crystal meth like the government's done with cannabis. But like I mentioned, in this current state of affairs, we could really help improve a lot of people's lives and help decrease the potential spread of COVID by prescribing. And ultimately, we need a better solution. But definitely, physicians have stepped up to the plate in the past, and that's what we're being asked to do now, to try and, support people who are very, very vulnerable and marginalized already, but now in the context of COVID-19, much more so.
Yeah, I totally agree. I think that this is like a medical solution to a problem that was created by the criminal justice system, and that, everyone deserves safety, and that I can certainly buy alcohol or I can buy cigarettes. And I mean, cigarettes are not safe, but or alcohol's not safe either sometimes. But that, I think about marijuana, for how many prescriptions I did for marijuana in my life, where I would think like, oh gosh, like there's really not enough evidence to guide how I prescribe marijuana. And it was very uncomfortable having these conversations with patients where they'd say, I smoke marijuana for anxiety. And I'd say, well, I mean, there's no evidence that marijuana works for anxiety. And they'd say, well, it works for my anxiety. And then, like, what do you do as a prescriber in that situation? I am so grateful that marijuana is now legal and people can just buy it if they want to use it. And it's not sort of shoehorned through medicine. And so I think that it's sort of parallel with this, in that this is a medical solution, like coming through prescribers to address harms that are created by the criminal justice system for people.
Thanks, Christy. I think I'm going to rush through our slides, Christy, a bit more now, just considering the time. I think those are really important slides for us to kind of take some time on that we have so far. So how does prescribing work? Okay, we skipped that slide. Good idea. We can skip this slide. Basically, the point of that slide.
I think it's important, though, to say that we want people to stay with their prescriber. So the best thing to do is to have your own patients that you talk with and you prescribe for them. So if you think about all the patients that you maybe have referred to IOD or TIOD, that those are the people you want to maybe call up and say, like, oh, okay, instead of being on that wait list, shall I just start you on some take-home dilaudid tablets? So we really want people to stay with the person that they know, who has a longitudinal relationship. You're the ones with their urine drug tests on file and are going to be following them over the next many years, perhaps, as this guideline and COVID are changing.
Thanks, Christy. And so many of you may have seen the Health Canada exemptions. And for those that haven't, I'll quickly just review them. Health Canada introduced new exemptions under the Controlled Drugs and Substances Act, which is actually very helpful for us as prescribers. So it permits pharmacists to extend prescriptions. It allows them to transfer duplicates, for example, between pharmacies, so we don't have to keep writing new ones when patients want to switch. It permits prescribers to issue verbal orders. And so I've done that already, called in hydromorphone prescriptions to pharmacists who know me, and they felt very comfortable as well. And then I just mail them the script later. And then it permits pharmacy employees to deliver prescriptions of controlled substances to a patient's home or other locations where they may be self-isolating. And there's a note there that this time it's really at the pharmacist's discretion in terms of if they feel that situation is safe and appropriate to do that delivery. But long story short, these things do make it helpful for us as prescribers and for patients as well. So patients on opioid agonist treatment and preparedness planning. So patients may be self-isolating, unable to attend appointments. We need to talk to our patients about COVID-19, help develop contingency plans. So ways to do that is, telemedicine visits, extending current prescription durations, considering pharmacist delivery. So if your patient does call you and say, hey doc, I have been, diagnosed with COVID-19, then we really want to try our very best to maybe change the way we used to do things. So, increasing someone's OAT over the phone, talking about what else they may need in this context, I think is really important. And then again, extending their scripts from what we're normally used to doing, knowing that patients can stay safe on their own and self-isolate. Christy, please jump in, hey, as I quickly get to these slides. Okay, guidance for prescribers. Document any changes you make to the treatment plan and their medications. Where possible, provide patient support using telemedicine and adjusting, doses through the pharmacy. Consider writing renewable prescriptions to reduce clinic and pharmacy visits. Consider individual factors when prescribing longer duration of carry doses. So patients presenting with any respiratory symptoms or in isolation may need more number of carries. Of course, respiratory symptoms, meaning that they're well enough to be home and not needing hospitalization, is something that we can easily rule out in terms of the patient's symptoms and get them to get care where they need. Provide longer carries. Longer carries may come with an increased risk of overdose, diversion, or risk to other household members. Really, we just want to ensure the patient receives counseling on safe storage of medication and access to a naloxone kit and adequate training on their use. I mean, drug users are very smart. I mean, they've been using substances, some of them for decades. They really know opioids, but when you give them hydromorphone or MS on it carries instead of, the fentanyl or carfentanil that where they have to really guess their safety with. But here, they may use more than 1 to 3 tabs with one shot because they know they can and they have that tolerance. So just trusting that we can provide this with that type of education. And medical legally, a really quick point, I did call the CMPA about our guidelines and physician risk medical legally, and the physician advisor said to me that it'd be very easy to defend us when we prescribe safe supply, because number one, key stakeholders have agreed. So the Ministry of Health, College of Physicians and Surgeons, College of Nurses, and also that we're going to really document well that we are giving carries, but we've talked to the patient about the risks, and we're going to document why we're going to do this, and that is defendable if there are any unforeseen consequences of this. and use clinical discretion to determine, sorry, that point, thank you. Use clinical discretion to determine the necessity of urine drug testing given the changing landscape. So you may not need to be, doing frequent urine drug testing at this point. Really is something that we probably should give away with until we can safely be seeing people in person again. So for Cadian or slow release oral morphine, just a couple of quick points that consider temporarily prescribing carry doses. I know traditionally with Cadian we haven't been doing that. We're clinically stable, and just ensure that if they are clinically stable and they have a secure place to store their meds for about a week, then do consider giving carries. And where daily witness ingestions deemed necessary, consider not sprinkling, because that sprinkling increases the amount of time a patient spends in the pharmacy and also the amount of touching of medications and potential spread.
Yeah, and if you're going to do take-home dosing, it's nice to do a blister pack.
Yeah, that's a great point. There are CSUs putting up bulletins regularly. There's this really helpful one on OAT for prescribers and pharmacists. Please take a look at that if you haven't seen it on the website, along with alcohol use disorder guidance, IOT guidance, and patient-centered, patient-forward materials that you can also find on the website. So Chrissy, do you want to get into the cases?
Sure. I'm conscious of the time, so we can breeze through these. These are not actual people. These are like composites of many different people put together with like name, everything changed. So this is not someone that you could identify, but this is something that's typical. So this past week, I had one of our patients, a 70-year-old woman. She's been known to us for many years on 120 of methadone, but continuing to muscle fentanyl almost daily and worried about COVID-19 because of her age. And, she's just had a lot of stress. She has nice housing at the PHS, and really wanted to not have to go see her drug dealer anymore. So I was on the phone with her on a telemedicine visit, talking through the options, and she requested MS-Lon 250 milligrams that she said she was going to muscle daily. I'm always surprised. I continue to be surprised that people are very specific about what they request and that they don't request the maximum. And I also said, since your housing is quite secure and that you've been stable on methadone for so long, like you've been on that 120, really literally for 10 years, why don't we put you on like Monday, Friday witness at the pharmacy just so you don't have to leave your room as much. But she wanted to continue to go see her pharmacy every day because they had also been her pharmacist for 10 years and it was a good social point for her to touch base with her pharmacist. So she continued on daily dispensing medication.
Great. So that I can maybe run through this case. So we have a 45-year-old woman under your care waiting for her COVID-19 test and is in isolation at your housing first project. So she uses crystal meth a gram a day, Ativan 1 milligram at night, and about a half a gram of fentanyl per day IV. So for this patient, we'll move on to the next slide. She agreed that she would want to have a long acting on board. She currently wasn't on any opioid agonist therapy, so you're starting her on an SROM titration. You've written an ongoing prescription from starting at 300, going up by 100 a day, and then providing her with Dilaudid, 8 milligrams, 7 tabs per day, some Dexedrine, SR, 20 milligrams once daily, and methylphenidate immediate release, 10 milligrams BID, and some Ativan at bedtime. Now, I mean, you might wonder why we chose these dosings, but really it ultimately is what the patient describes. So for stimulants I've found thus far, the patient actually knows. They've used Dexedrine or methylphenidate before. They know which one would work better. So they might tell you, I'd rather have some immediate release of some Ritalin and then a little bit of Dexedrine SR long acting as well to support me. And then with regards to Dilaudid, I've noticed that patients have been really underdosing themselves currently, and that, as Christy had mentioned, most people, don't go for the max dose immediately, but they say, I maybe 4 daily 8s would be enough. I use about 4 times a day. But again, I have found using 16 to 24 milligrams per shot of what they may be using to be a pretty good estimate. And in terms of safety, we know that, again, in the tie-up program, the 16 milligrams was a bit low, but no one overdosed off that dose. And so this is an example of something you could potentially do for that person. And then having regular follow-up. So a telephone visit with this patient every second day. And then as things are more, you feel pretty comfortable, you can, decrease those telephone visits as you see fit.
Yeah, to note here that some prescribers will do an increasing prescription like that, but it really depends on the context. I don't often do it because I find it administratively often doesn't work out, that there's missed doses. But we have nurses in all of our buildings who see the person every day, who can call and talk with the clinician. So I think that things like that depend really on your context. So that might not be appropriate elsewhere.
And then long-term care plans, patient and substance specific planning, shared decision making, nothing abrupt should happen, documenting of functional changes, overdosing, housing, drug use. So I mean, that's really key for us. Even that's what the CNPA recommends, that we really show the benefit and document it well, and different plans for different substances. And so this will require careful and robust evaluation and study. As prescribers, we make shared decisions with our individual patients. So it's really key to know that we really want to, build that relationship and involve them, because they can really be helpful in figuring out what they need, of course, because that's what they know. And knowing that the BCCSU is doing a robust evaluation of safe supply prescribing. So we'll hopefully have more evidence for this moving forward.
Fantastic. Thank you so much, Dr. Brower and Dr. Sutherland. I'm going to move us over now for the last 10 minutes to do some Q&A. So if you are logged in and you'd like to ask them a question, please do so in the chat function. To pull that up. 1 sec here. Okay.
Easy questions only, please.
Okay, so we'll kick us off with an easier. If a patient falls off a map in terms of follow-up, do we continue the scripts? If so, for how long?
Yeah, I mean, I would continue the script. I often talk to the pharmacist, and so sometimes even the pharmacist will just like put on speakerphone or something. So if the patient comes back to the pharmacy, then you can talk with them over the phone. But if I have it flagged for me that day that someone's methadone is up and they don't come into clinic, I look at their PharmaNet and I call up the pharmacist and I extend their prescription. And I think that that's quite appropriate even outside the COVID context. But especially within COVID, you really don't want our patients coming off MAP, especially on methadone and Cadian, where missed doses means dose reduction. And if someone has been on a good therapeutic dose for a long time, you don't want to lose those gains.
And if I could also add, in this context of these new medications and patients having more hope that they finally may not have to use illicit, I think that, for me, I've said to patients, look, I'm going to call you at this number, or I'm going to follow up with this person so we can get in touch. They've been really grateful to say, yeah, let's do that. Versus with methadone, maybe when they don't come in, or sort of something that hasn't really been as helpful for them maybe in the past, and the follow-up becomes less of a priority if they're continually having to self-treat. I think that we may find that would be less of a problem with these guidelines, but it's definitely time will tell.
Yeah, and you can definitely use the interdisciplinary team. I feel so grateful to the nurses and social workers and support staff in housing who will call us and say, I tried to get Tim to come to the clinic today, but he, for some reason he doesn't want to. Patients are chaotic and they're living their lives, and it's not always their top priority. But it's wonderful when you can talk with that nurse and say like, okay, but you've seen them every day for their wound care and they're alert and they're looking well. So I'm going to look at their PharmaNet and I'm going to fax in an ongoing continuation of this prescription.
In terms of storing medications, what would happen with our homeless clients? Is there a plan in place?
Well, at the PHS, I can only sort of speak to PHS things, not provincially, but at the PHS, we're installing like a locker, like at my gym, they have like little wallet lockers. So we're going to install one of those inside the shelter. But I think it's really context specific, and that you would have to call up the people who are running the shelter and say like, what are the options for this person if they're on a carry? Could you purchase them a lockbox? Those kind of discussions.
And you might find that you're going to end up, if that's not possible, daily dispensing, or getting them to pick up every 2 days because they feel they can safely manage 2 days of meds, and that more than that might be a bit of a risk for them. And so I would really just talk to the patient about what they feel they can do in this context.
And I'd also interject that drug users know how to handle their drugs and carry them as well. So we don't need much help in, holding onto our substances.
Thanks, Guy.
When COVID is over, what is our strategy when we need to continue prescribing this? What does, beyond COVID look like and safe supply?
Well, I think that's $1 million question. So that's why in these guidelines right now and in this presentation, we're emphasizing that this is a framework for prescribers that is in a response to a pandemic, and that you need to follow your patients ongoing, and that nothing is abrupt. Like COVID is going to continue to be a problem for a year, 18 months from now. So we have a lot of time to evaluate how this rolls out and see what happens. and that it will be different for each substance and each person in each context. That for me, the benzo literature is quite compelling to show harms from benzos, and so I don't want to be prescribing things that cause harm. And that right now I'm going to prescribe benzos because I feel the harm from COVID is higher than the harm from benzos. But once COVID is done, I'll taper my benzo patients. But for opiates like hydromorphone, I have had seen my patients get really a lot better on the TIOT program, and that TIOT was moving maybe to take-home dosing anyway. So for them, I'll make patient-specific plans based on how they do over the next year, to say like, oh, they used to overdose all the time and now they're not overdosing. They were off their ARVs, now they're on their ARVs. They were doing sex work and now they're not. Now they're housed and connected with their family and working. And so I think this will be large-scale evaluations and research, and as well as clinicians, it's our individual decisions for risk and benefit within this framework. So the answer is I don't know, but that we're just going to use our clinical judgment over time, and that these guidelines are, you know, they're not presented as something that's permanent, and so we'll see where we land. I think. I don't know if I was vague enough / specific enough to make anyone happy with that answer.
If I could also add that the BCCSU, I mean, in conjunction with Christy, I mean, as a coach, are working on safe supply guidelines moving forward anyway. So this was something that was going to come out later with multiple stakeholder engagement, but in the context of a pandemic, something a bit different has come out very rapidly. So, you know, I feel personally, I can speak for myself, reassured that if I can document, like Christy said, benefit, I'd be hard pressed to see the college being upset with me if I can say, well, you know, I could stop the hydromorph, but then they would use fentanyl and they're the impact of that could be death. And having had conversations with the college about these very guidelines when we were developing them, they're very reasonable and on board with regards to decreasing harm for people. So anyway.
If clients are using both street opiates and crystal meth, can you prescribe both safer supply options at the same time?
Yes.
Yes.
Please do.
If patients lose or use up their 23 supply very early, what is the suggestion to manage the situation? Weekly dispense seems reasonable? Question mark.
So I can give an example of a specific case where the person said to me, and he uses a 1/4 gram a day of fentanyl and a 1/4 gram of crystal meth. And he uses it for both of them together 4 times a day. And he said, Doc, I only want 4 Ritalin IRs, 10 milligrams, and only 4 dilates, and that's all I need. And I was like, well, that's not going to be enough. He's like, nope, I don't want it anymore. And I felt it was almost because he felt he just was so grateful for this that I don't want to act greedy or push it. And of course, day 2, he felt very sick. And so he used up that supply, and I had given it as a carry 3 times a week, used up immediately, and that made sense as to why that would happen. But I would say the 23-day supply doesn't necessarily mean that you give 23 days of carries, but you could initially, just to gauge how the patient will do, give it weekly or give it, you know, twice weekly. And then eventually when you have a dose that you know the patient is more stable with, you can increase the number of carries. But yeah, the 23-day number is more based on viral shedding and supporting ongoing isolation than it is, you know, recommending a 23-day carry in every case.
Yeah, it was prescription duration, not carry duration.
Good point, yeah.
With diminishing supply street value, these medications will be high. Diversion seems an appreciable risk. How will this be mitigated?
I think that diversion is something that we've always been so concerned about, and that's really, I think, prohibited us from being able to expand our prescribing, for example. And I think it is, I mean, there is some risk, but, you know, speaking to people with lived experience, and, you know, they say that people that want to take their medications are going to take their medications because they need them, especially in the context of a dwindling drug supply. But ultimately, if someone's going to divert, anything we do like DWI or sprinkles, all that, you know, people are crafty and when they need to be for survival. And so it isn't necessarily true that all these things that we've put in place have really prevented diversion altogether anyway. So I think that for me, it's a moot point at this point in time, and that I just really want to support people with safe supply. And, you know, you're going to have ongoing assessment with your patients too. And if things aren't improving for them and you're getting a sense that things are getting worse, maybe, then you want to reassess your plan. But I think that if we worry about diversion, we won't be able to really support our patients. And is it really at that big of a risk? It's, you know, we don't really have evidence for that.
Okay,
yeah, for me, I can chime in as well, that I think that our risk calculation has changed because of COVID, and that this patient population is at very high risk of getting COVID and death. And that I think with the dwindling drug supply, what it makes me worried about actually for my patients who I'm giving safe supply to is violence. because I'm worried that, especially for women or vulnerable populations, that people will be trying to steal these drugs from them, especially if that person's homeless. Like I think we've started a little outreach clinic in the tent city in Oppenheimer Park. And so it's really important to have a good discussion with someone and say, like, are you safe to be using these drugs? And then we talk with our staff at the PHS about how we interact with drug dealers to try to protect people. And so often when people are homeless and then moving into housing, it's a really good opportunity to start them on safe supply, because it's sort of like a breakup with your drug dealer, and your drug dealer doesn't know where you've gone to come and assault you.
Great. One final question. We are mostly seeing patients by telehealth visits. Would you recommend to start anyone on OAT or this DILI-8 program without a urine drug screen?
Yeah, that is a hard one that we have been talking about as well. It's best to get a urine drug screen if you can. So even though we're doing telephone visits, often there's a nurse or a worker there in person, or maybe an outreach worker who can get the urine. And then that will really make you feel a lot better. If you can look on their PharmaNet and see, oh, they're not on OAT right now, but they were on methadone in December, that's also quite reassuring. If the person who's with them to help them with the phone call, if there is an outreach worker there, can see if they have track marks or not. But it really is a balance for each context in each specific situation, I think. I think under the right circumstances, I would start this without a urine drug test, but that would be when I've exhausted all other options and I feel quite sure that the person has an opiate tolerance. But I would definitely be more cautious, I think, with my prescribing in that context.
Thank you so much, both. So with that, I'm going to wrap up the webinar, just hearing or seeing that we're at time. Recognizing that we had a number of questions from folks, we're going to do some follow-up on this webinar and potentially offer another version of this webinar that will be more Q&A focused, just recognizing the large number of questions that are coming through our chat. So a big thank you to Dr. Christy Sutherland, Dr. Rupi Brar, and Guy Felicella for offering this webinar today, and we sincerely appreciate you attending on behalf of the BC Centre on Substance Use. We're going to end it there. Thank you so much for joining, and stay tuned for more from our team.